So we went over improving ventilation, so that basically meant how would you control your CO2. And we talked about controlling the tidal volume, going up on the tidal volume or going down, going up on the respiratory rate or going down, and then removing dead space, okay? So now we're doing what are the things that you can do to improve oxygenation, okay? So everything here will impact your oxygenation. The level of the FiO2 that you're using, your O2 saturation, these are indices of oxygenation. ABG, because you gotta do ABG to find your PaO2. Hemoglobin carries the oxygen. If you don't have enough hemoglobin, you will die of hypoxia, okay? PaO2, PF ratio, and then the PP ratio. Shunt, whenever you have high shunt, it means that you're not oxygenated well. Cardiac output, if you don't have adequate cardiac output, then your tissues will not get adequate oxygenated blood. And then SVO2, that is called venous oxygen saturation, the amount of oxygen saturation in the venous blood. And then you have the CVO2, venous oxygen content, the total amount of oxygen in the venous blood. Okay. So let's take them one at a time. So the first one is FiO2, and then it stands for fractional inspired oxygen. FiO2 increases PaO2 and SaO2 when hypoxemia is caused by vacuum mismatch. Like I said before, if a patient has hypoxemia on FiO2 that is less than 60, then you're going to say that they have vacuum mismatch. Okay. Vacuum mismatch just means that ventilation is fine, oxygen is not. Okay? And the best way to treat vacuum mismatch is to increase the FiO2. We have to increase the FiO2 so that the PaO2 can increase and match with the CO2. Okay, so that's what it means. For a low PaO2 and FiO2 between, I've already told you that. FiO2 greater than 50 is potentially unsafe. FiO2 greater than 60 is toxic. So if anybody that is going to be on any FiO2 that is greater than 60, they must need PEEP. Okay? If they're already on PEEP, you add more PEEP, unless the PEEP is causing problems. Okay? Now, just like we went over a formula for adjusting ventilation, there is one for adjusting oxygenation. Now, this one is how much FiO2 would you need to get a certain level of PaO2. Okay? Now here's the one for ventilation again. We did like desired rate equals known rate times known CO2 divided by desired CO2. That's the one for ventilation. And then we said that tidal volume can take the place of respiratory rate here, because tidal volume impacts ventilation. Mini volume can take the place of respiratory rate, because mini volume impacts ventilation. Alveolar ventilation can take the place of that. So, the same formula. Okay? But now for the FiO2, it is desired FiO2 equals FiO2 known times PaO2 desired divided by PaO2 known. Okay. Now this one here works better than this one here, because if a patient has shunt, this will not work. Okay, because once they get that shunt, no matter how high that you turn your FiO2, they will not oxygenate. It just basically means that, the alveoli are collapsed. You gotta open them up with PEEP. Okay, so that's why this doesn't work very well. But if the patient doesn't have any shunt, it will work well. Any questions about that? Or should I do an example? Should I do an example of this?
Sure.
Yeah, okay. SaO2 and PaO2. Normal arterial oxygen saturation is 95 to 97%. Only will you get anybody that's 100%, because everybody has a minimum level of carboxyhemoglobin in them and a minimum level of methemoglobin in them. For instance, if I have carboxyhemoglobin of 3, the maximum that my oxygen saturation will be is 97. Okay, if I got 1 methemoglobin, 5 carboxy, the maximum my oxygen saturation will be 94. Okay? So acceptable is 90% or greater. Okay. Clinically, if a patient has O2 saturation that is greater than 90, we're good. Okay? It doesn't mean that it's normal, but it's acceptable. SaO2 decreases with the decrease in PaO2. Okay, that is true. Here's your hemoglobin here. And here is the PaO2 on the hemoglobin, the partial pressure of oxygen. So the more oxygen that you have attached to the hemoglobin, the more saturated the hemoglobin is with oxygen. So as you increase your PaO2, your oxygen saturation should be going up. Okay? So oxygen saturation is the amount of oxygen attached to the hemoglobin. Okay. PaO2 is the amount of oxygen dissolved in the plasma. Okay. So if you don't have enough PaO2, you will not have enough saturation. So we have to increase your FiO2 to increase your PaO2 to increase your oxygen saturation.
So say that one more time. The SA2 is
Which one?
Say it one more time.
Okay, SaO2. Okay, SaO2 is arterial oxygen saturation, the amount of oxygen that the hemoglobin is saturated with in the arterial blood. Okay, so normal is 95 to 97%. So if your hemoglobin is 95 to 97% saturated with oxygen, that's good. Acceptable 90% or greater. Okay? Now, the SaO2 decreases, okay, when the PaO2 decreases. Okay, because the hemoglobin picks up the oxygen to be saturated with oxygen. Okay? But if you don't have any oxygen, enough oxygen in the plasma for the hemoglobin to pick up, well, your oxygen saturation is going to be low as well. Okay?
So the PaO2 is dissolved in the plasma?
Yeah, is the partial pressure of oxygen in the plasma. So now you talk about hypoxemia. Hypoxemia is low level of oxygen in the blood, which is in the plasma. Hypoxia is low level of oxygen in the tissues. So how do you get hypoxia? Well, if you don't have enough hemoglobin, you're going to have hypoxia because the hemoglobin transports the oxygen down to the tissues. Okay? So if you have hypoxemia, you're going to have hypoxia. Okay? But you can have normal PaO2, which means you don't have hypoxemia, but you will still have hypoxia because you don't have enough hemoglobin. Right? Decreases with dysfunctional hemoglobin. Carboxyhemoglobin and methemoglobin, those two are called dysfunctional hemoglobin because they mess up the hemoglobin that cause the hemoglobin not to pick up oxygen. Okay? So when that happens, oxygen delivery to the tissues will decrease. Okay? Not a whole lot of PaO2 will attach to the hemoglobin because of those two. Okay? Normal PaO2, 80 to 100 millimeter of mercury. increases with the FiO2 in the absence of intrapulmonary shunt. Intrapulmonary shunt is atelectasis. Your lung units are collapsed. That's all it means. Okay? And once they're that way, unless you add PEEP, you're not going to get anywhere with oxygenation. Increases with increasing PEEP level. PEEP is an oxygenation index. PEEP is an oxygenation index, but it can indirectly improve your compliance, right? We can add PEEP to improve compliance. Because when you ventilate better, you oxygenate better. So PEEP is an oxygenation index. But you cannot increase PEEP or decrease PEEP to control your CO2. Okay? But when the CO2 is high, you will not be messing with your PEEP. But when your PaO2 is abnormal, then you'll be messing with your PEEP or your FiO2. Shunt. Shunt is the percentage of blood that does not get involved in gas exchange. A percentage of the cardiac output, let's put it that way. Now let's say that my cardiac output is 5 liters per minute. That's the amount that got pumped out from the left heart in 1 minute. 5% of the cardiac output, whatever your cardiac output is, 5% of it will not get involved in gas exchange. When your blood pumps out from the left heart, there are 3 veins, because it's supposed to go into the artery now. But there are 3 veins that some of that blood will go into. Okay? You have bronchial vein, pleural vein, and the basal vein. So 5% of the cardiac output, and this is something, 5% of that cardiac output will go into these 3 veins here. And therefore will not participate in gas exchange, because once that blood pumps out, they're going into the artery. But 5% of it will go into these 3 veins. So that's how come we come up with saying that normal shunt is 5. See that? Normal shunt is 5 because 5% of your cardiac output will not participate in gas exchange. Okay? So the higher shunt that you have, the more hypoxemic that you're going to be. Okay? So higher shunt will mean that you have a higher percentage of your cardiac output not participating in gas exchange. So now, like I said, normal shunt is 5. 20 or less is acceptable. You gotta remember that number. 20% or less shunt is acceptable. In most cases, we don't start doing anything until the shunt is greater than 20%. Cardiac output, normal cardiac output is 4 to 8 liters per minute. The amount of blood pumped out from the heart in 1 minute. Yeah, well, what pumps out is oxygenated blood from the left side. So if you have a decreased cardiac output, then that means that the organs and the tissues will not be getting adequate oxygenated blood. So they will die of hypoxia. So that's why cardiac output is partially a measurement of oxygenation. Hemoglobin,
Except for the shunt is acceptable as less than 20%.
less than 20% or less. 20% or less is acceptable shunts, but 5% is normal. Some books will say 4 to 5. Hemoglobin, 12 to 14 for females, 14 to 16 for males. Hemoglobin is very important. Like I said now, you may have all the oxygen in the world in your plasma. Your PaO2 can be 1,000. 1,000. But if you don't have enough hemoglobin, you are still going to have shortness of breath. Because you're going to have hypoxia. There's nothing carrying the oxygen down to the tissues where we need the oxygen. Okay? So now remember now that if you really want to look at the total oxygenation status of a patient, you have to look at the oxygen attached to the hemoglobin plus the one dissolved in the plasma. Now, PaO2 tells you just a little bit. It's a little bit picture that you got enough oxygen in your blood, but you may not have it down in your tissues. So that's why we have what we call that oxygen content, that long formula. That says CaO2 equals hemoglobin times 1.34 times SaO2 plus PaO2 times 0.003. So, this is the amount of oxygen dissolved in the plasma. There is 0.00 milliliter of oxygen dissolved in the plasma per unit of pressure of PaO2. So now you can see now, let's say that your PaO2 is 500. You multiply by 0.003, you get nothing. It's very negligible, right? But now, by the time you multiply your hemoglobin by 1.34 and your O2 saturated, you don't have a huge number. So most of the oxygen is attached to the hemoglobin. Okay, so this is the best index of oxygenation, CaO2, not PaO2. PaO2 just gives you a little picture of it. Okay? SVO2, venous oxygen saturation. Okay? The hemoglobin in the venous blood, how much oxygen does it have? Okay? 75% is normal. I'll make it 65 to 75%. Normal arterial saturation is 95 to 97%. Normal venous saturation is 65 to 75%. It won't be the same with the artery because the tissues have already used up the oxygen. CVO2 is the total amount of oxygen inside the venous blood. Very similar formula. It goes like CVO2 plus hemoglobin times 1.34 times SVO2 plus PVO2 times 0.003. Number for this is 20 volume percent. Number for that is 15 volume percent. We're going to talk more about this when we do the hemodynamic course. So you see that very similar. the total amount of oxygen in the venous blood, you take the hemoglobin, okay, in the venous blood, the amount of oxygen that is saturated with, plus what is dissolved in the venous blood, the amount of oxygen, PVO2. So PVO2 is the partial pressure of oxygen in the venous blood. PaO2 is the partial pressure of oxygen in the arterial blood. Okay? So, these two here are very important because what happens is that anytime there is a decrease in cardiac output, the oxygenation status in tissues goes down. And then the tissues will begin to extract oxygen from the venous blood. That's what happens. If your cardiac output goes down, the tissues will begin to extract oxygen from the venous blood. So that's why we have to look at it. So in essence, if my PaO2 is my SvO2 is going down, or CvO2 is going down, that tells me that cardiac output is decreasing because tissues are extracting oxygen from that blood. Any questions about that? Okay, now PF ratio is basically how much FiO2 are you using to get this PaO2? That's what it means. How much FiO2 are you using to get this PaO2 right now? So let's say that I am a roommate and my PaO2 is 80. And I'm breathing 21% oxygen on roommate. So I'll divide 80 by 21. That should be about what, 395, something like that. 80 divided by 0.21. Huh?
380.9.
380. So that's normal PF ratio. Okay? It can be more than that. Okay? Because normal PaO2 is 80 to 100. Okay? So if your PaO2 is 100, you divide it by 21%, it's very close to 500. Okay? Okay, now, think about this here now. Somebody's got a PaO2 of 80, but they are wearing like 60% oxygen. Divide that out, Brian.
133.
133, very good. So now, these two patients, which one would you say that is oxygenating better?
This one?
Yeah, because this guy here is only using 21% to get a PaO2 of 80. This guy is using 60% to get a PaO2 of 80. So we look at that, that's called the PF ratio. How much FiO2 are you using to get this PaO2? Well, if you're using high FiO2 to get a reasonable level of PaO2, then something is wrong. That's not good oxygenation. So, when you divide your PaO2 by your FiO2, and the number is 300 or greater, that's acceptable. It doesn't have to be 380, it doesn't have to be 455 or whatever. But if you get 300 and above, that's acceptable. Well, it's okay for us. But now, if you divide both of them out, and you get a number between 200 to 299, what we call that is acute lung injury. Some kind of injury inside your lungs, acute lung injury. So on the exam, they may say, well, a patient has a PF ratio of 250. Okay, which of the following will you diagnose? Well, you say acute lung injury. If it's less than 200, when you divide the both of them out, you have ARDS, adult respiratory distress syndrome. Taking care of a patient and now all of a sudden their PF ratio falls below 200. They've gone into ARDS. That's one way to make diagnosis of adult respiratory distress syndrome. PP ratio or P small a over P big A ratio. It's important for you to understand that, but we don't really look at it like we look at the PF ratio. But this one here is like this. Here's the alveolus. Here is the blood. Well, inside the blood we have the P small a O2, which is arterial, partial pressure of oxygen in the arterial blood. P bigger O2 is the partial pressure of oxygen inside the alveolus, inside the lungs. Well, if you work out this formula, the alveolar A equation, if you all remember that, alveolar A equation. And now, alveolar A equation is used to determine the partial pressure of oxygen inside the alveolus. When you work it with normal barometric pressure, normal water vapor, the FiO2, CO2 40, you got about 40 here. About 100 here. So the partial pressure of oxygen inside the lungs approximates 100 millimeters of mercury. It's 99 point something. But in here, the most that you can have here is 100. That's the most you can have. But if somebody's hypoxemic, it will be less than 100. Okay, let's say probably 60. So we talked about concentration gradients. If you have more on this side, then more has to move to the other side. So I have more here. So oxygen is always going from the lungs into the blood. And then I have more CO2, for instance, in the blood than I have inside the lungs. So carbon dioxide is diffusing from the blood into the lungs to be exhaled out. So what we're measuring with this is how much of the oxygen you have in here is diffusing into the blood. What is your diffusing capacity? What is your diffusing capacity? So if you have 80% to 100% of the oxygen in the alveolus diffusing into the blood, well, that's good diffusion. Okay, that's good. Because a lot of things can go wrong with this here, the alveolar capillary membrane here. A lot of things can stop that oxygen from diffusing into the blood. If you have scar tissues there, we'll call that pulmonary infection, that will impede oxygen diffusing into the blood. If you have water inside your lung, like pulmonary edema, that will impede that. If you have atelectasis, reduced surface area, that will impede diffusion. Okay? So that's what this is looking at. 80% to 100% of the oxygen crossing over from the alveolus down into the blood. That's good. Okay? Any questions about that? PEEP. Like I said, that PEEP is an oxygenation index. It has nothing to do with adjusting CO2. Okay, now, but now if you have low PaO2, you can consider increasing PEEP, especially if you have gotten to FiO2 that is above 60. Okay, you need to add PEEP. If the patient is already on PEEP, you increase PEEP. Okay, so positive end expiratory pressure, the amount of pressure left in the lungs at the end of exhalation. Now, PEEP is the same thing with CPAP. Make no mistake about that. It's the same thing with EPAP. A PEEP of 5 equals a CPAP of 5 equals EPAP of 5. Okay? We'll call it PEEP on the ventilator when the patient is not breathing spontaneously. We'll call it CPAP when the patient is breathing spontaneously. We'll call it EPAP on the BiPAP. The indications, contraindications, complications of PEEP, CPAP, and EPAP are all the same. Okay? Indications for PEEP, CPAP, or EPAP, we use it to treat intrapulmonary shunts, which is atelectasis. Now that. We add PEEP, we restore the surface area for gas diffusion. We blow it back up, so we can have more surface area for gas to diffuse into the blood. And that way you increase oxygenation. That's the way PEEP improves oxygenation. Okay? Improves compliance, yes. You know, if you keep on distending the lung unit, you know, more pressure in there is causing it to stretch like that. It's like when you get a rubber band, initially when you start doing this to it, you're gonna find out that it's very difficult to stretch. But over a period of time, as you keep on doing this, you're gonna find out it's easier now to stretch it. This is the same thing there, the same idea there with people. You leave that pressure in there in the lung over a period of time, it will make the lungs more compliant. So, to summarize that, on the exam, if you're given a very low static compliance, you add PEEP. If you're given a very high plateau pressure, you add PEEP. Because high plateau pressure means that you have stiff lungs. And then when you divide that high plateau pressure by your tidal volume, you have low static compliance. Okay, so two ways to look at it. Low compliance and low static compliance, lungs are getting stiff. Then you add PEEP. Low, high plateau pressure, the same thing. It means the same thing because the plateau pressure is the amount of pressure used to actually ventilate the lungs, not the PIP. PIP has two pressures in it. FRC, we can use it to restore FRC. The number of FRC in the adult is 2,500 milliliter. This unit, this lung unit here cannot contain that much volume. But when we blow it out for PEEP, it can contain 2,500 milliliter. So we use it to restore FRC. Reduce inspiratory pressure, that is true. If you already got PEEP in there to distend your lungs open to some extent, then you wouldn't have to breathe in more pressure to completely open it out. So a lung unit that has been distended open to some extent will take lesser pressure to completely inflate than a lung unit that has not been distended open at all. Other indications for PEEP and CPAP, CHF or pulmonary edema. Okay, PEEP, positive pressure, not just PEEP on the ventilator, but any kind of positive pressure is good for fluid problem. CPAP, BiPAP, EasyPAP, ventilator. Okay, positive airway pressure, any kind of PAP. Now, positive airway pressure. What is a positive pressure? Positive pressure is any pressure that is greater than ambient pressure, greater than 760. So, here's the barometric pressure here. If somebody has 765, we'll come up with a PEEP of 5. That's how we come up with that. So it's 5 points greater than ambient pressure. That's what we're saying. If they have 780. Then they have people of, people of, 20, no, people of 20, yeah, that's right. People of 20. Because 20 points greater than ambient pressure. So that's how we come up with that positive pressure. Okay? Negative pressure is any pressure level that is less than 760. Okay? All right. So they have pulmonary edema. Think about PAP therapy, easy PAP, CPAP, IPPB. All those things will give you positive pressure. Okay, positive pressure will push the fluid inside the lung tissues. Okay, especially we use the CPAP a lot to patients that have CHF, and that's the reason. Okay, we want to take the pressure, push the fluid inside the tissues. Athletics is like this. We add PEEP. The patient has athletics. And now the PIP on the ventilator is going up. We're going to add PEEP. Sleep apnea. That's CPAP, that's PEEP. We use the pressure to split the airway, move the offending tissues out of the way so that the air can go into the patient's lungs. Cystic fibrosis, they make a lot of secretions, a lot of thick secretions. So we're going to use pressure to displace the secretions. It enables the secretions to move up to the upper airway. Flared chest, we talked about that. Okay? You lose mechanical advantage on that side where your ribs are broken. So we're going to use PEEP to make that area more rigid. Okay, so the ribs will try to go out during inspiration as opposed to sucking in, which we call the paradoxical ventilation. Levels of PEEP, 2 to 6. That's called minimal PEEP or physiological PEEP. Minimal PEEP or physiological PEEP. Now, physiological PEEP is the amount of PEEP that everybody is supposed to have in them. Okay? The amount, everybody has normal amount of PEEP, on the average 5. Okay? So, if you really put somebody on a PEEP of 5 on the ventilator, it's really nothing unless the patient has severe hypotension. Because that's what you're supposed to have anyway. Okay? If you have other issues, then the PEEP of 5 may cause problem. Otherwise, it's really nothing. Okay? Because all the patients that are going to go on the ventilator, we'll start them with some level of PEEP. Therapeutic PEEP is between 10 to 15. Okay, so if you want to say that somebody is on PEEP therapy, this patient is receiving PEEP, it's actually a PEEP of 10 or more. A PEEP of 10 or more is what we call PEEP therapy. So that's how come initially when you're going to put your patient on the ventilator, you never start them with a PEEP of 10. You start them with a PEEP level less than 10. That will be physiological PEEP. But then if you have a reason to increase the PEEP or start the PEEP at 10, you can do that. Like, I'm already at FiO2 of 60 and my patient is not oxygenating. I can just start them with a PEEP of 10. Okay? I can go higher than that if I need to. And then we have optimum PEEP. Optimum PEEP is the level of PEEP that gives you the best oxygenation without causing complications. Okay, we're going to do an example of that. Do I have it here? No, I don't. Okay, so I'm going to do an example in a minute. So optimal PEEP is the level of PEEP that will give you the best oxygenation without causing complications. And then maximum PEEP is any PEEP level that is greater than 15. Okay, the usual is a 15 to 24. But I told you the other day that the only guideline for giving PEEP is that you keep on increasing PEEP until you get the PaO2 that you're looking for, or you have a side effect. So don't worry about maximum PEEP. You can go as high as you need to go until you have a side effect or you get the PaO2 that you're looking for. So don't let that confuse you on the exam. If they say increase PEEP to 30, well, if you don't have any side effects from where you are currently at, then you increase PEEP. Okay? So let's do optimum PEEP, because they ask a lot of that on their board exam. The level of PEEP that will give you the best oxygenation without causing complications. Okay, so here I start with P level. I start with static compliance, PaO2 there. And then I'm going to use, let's use blood pressure for complications. See, now see, high PEEP will decrease your blood pressure because it decreases during short time. So blood pressure will be the complication that I'm going to be monitoring while I'm increasing my PEEP. PaO2 is what I'm going to be monitoring to see if the level of PEEP that I'm at is good enough. Okay, so now, let's say I started with a PEEP of 5. My lung compliance, static compliance is 40. And currently my PaO2 is 50. And my blood pressure is 150/90. That's too high, so that PEEP is not causing any problem, because what PEEP does to blood pressure is to decrease it, but right now it's high. Now, if you look at this, I'm not pleased with a PaO2 of 50, because that's the reason I'm giving PEEP. That's still abnormal oxygenation. So, on the ventilator, I decided to go to a PEEP of 8 to try to up my PaO2. As we would expect, compliance should increase because PEEP improves compliance. Let's say now, because of PEEP of 8, I'm getting 50 milliliter of volume per unit of pressure. So my compliance improved. My PaO2 should improve at least, because I got more PEEP now. I'm opening it up some more. So let's say that it goes to 60. And then I have more pressure now, more positive pressure. So that should, touch on my blood pressure. So let's say that my blood pressure goes to 145/89. Well, I'm not pleased with that PaO2 because that's not normal PaO2, right? So I can go up on my PEEP to see if I can get more PaO2. So I go to PEEP of 10, compliance should improve. Let's say compliance improves to 60. My PaO2 should improve because that's more pressure, opening up the lungs, 70. And my blood pressure should go down some because that's more positive pressure. So I'm at 120/80. That's normal blood pressure. Well, I'm not pleased with the PaO2 of 70 yet. I want to get it to 80. So now, let me try PEEP of 12. Compliance improves to 65. PaO2 improves to 80. My blood pressure drops to 90/40. I have a problem. I have a complication here. So this is my optimal PEEP, the PEEP of 10, because it is the level of PEEP that gave me the highest oxygenation without causing complications. Any questions about that?
So, in this scenario, let's say like, and this probably isn't for the boards. This is probably for like real hospital stuff. But like 10 is the optimal PEEP, but the patient is already on 100% oxygen. Would you, in a hospital setting, still go up to 12, but just maybe like give them like blood pressure or something?
Yeah, you look at other things, like sometimes there's something called proning. You flip them over, so you can ventilate the lungs back here. Okay, you can try that. You can do an inverse ratio ventilation. Okay? Now, indirectly, that's more people, but you can try that as well. So a lot of other things, you can diurese the patient if you feel like their lungs are very wet. Okay? But anytime a patient is having complications with PEEP, you can't keep on going up on PEEP. Okay? You have to go up on the FIU until you get to 100%. I'm going to do one more. But what I want to tell you is that on the blood exam, they can use a lot of things for complication instead of the blood pressure. Okay? So here is this one here. PEEP, study compliance, PaO2. Yeah, let's use cardiac output because PEEP decreases cardiac output. It decreases blood pressure. Okay? All right, so start with a PEEP of 5, compliance is 30, PaO2 is 60, my cardiac output is 8. What's normal cardiac output?
48.
48. So that's okay right now. Basically, it means that this PEEP of 5 is not causing any problems. All right, give me a minute. Hello? Now, so I'm not pleased with PaO2 of 60, so I said to try a PEEP of 10. That will go up. That went up. That will bring the cardiac output down some. I still have normal cardiac output because it's 48. So I go to 12, that 50, that goes to 75, and now I am at, let's say 5. I'm still okay, I can give PEEP. I want to get this to 80, so I go to PEEP of 15, 55, 85, and then I have 3. So my optimal PEEP is 12, because that's the level of PEEP that gave me the highest oxygenation without causing complications. Any questions about that? There are a whole lot more that they can use for this column here, but we're going to talk about those other values when we do the hemodynamic course. Okay? Other PEEP. Other PEEP is the amount of PEEP that you did not set. You did not set. It's air trapping. Okay? You can call it air trapping, you can call it intrinsic PEEP, you can call it inadvertent PEEP, you can call it occult PEEP. Okay? It's just the PEEP that you did not set. Okay? Causes of older PEEP. Airway obstruction. All the CBABs. If we start with emphysema, for instance, you lose some lung fibers so that their lung units do not rebound with force. That's how come, they don't excel anything out. They lose the elastance, they don't rebound because they lose some fiber. The cigarette smoking causes them to lose a lot of fibers in their lungs. So they have good compliance because they have less fiber, but they have poor elastance. That's one of the things that causes air trap and emphysema. You take asthma, for instance. Asthma will have bronchospasms. Okay? This is the normal airway. All of a sudden, it will spasm, and the diameter decreases. So you have less air going out. They do air trapping. You take cystic fibrosis, where they make a lot of secretions. The secretions are in the way of the air getting out of the lungs. Bronchiectasis, they have dilation and rupturing of the bronchial tree. The air doesn't go out. So either way you go, the air is not coming out. So obstructive diseases. You aspirate something that's in the way of the air coming out, you're going to have air trapping. Like the other day we were talking about the bulb valve effect for meconium aspiration. And when the baby swallows that, aspirate that meconium, when they breathe in, the airway gets a little wider, and then the meconium moves further down. During exhalation, it closes back up, trapping air with it, okay, behind it. So any kind of obstruction will result in ODP. Excessive mini volume. Okay. The more tidal volume that you breathe in, the more time you're going to need to exhale it out. Okay? So you can clearly see here that when tidal volume goes up, eye time goes up. Tidal volume goes up, eye time goes up on volume control mode. So if you set a patient up on a huge tidal volume, okay, but you give them a very small E time, they will do air trapping because they don't have enough time to exhale all of that volume out. Okay? Actively contracting expiratory muscle, yes. Like COPD patients, their airways are very floppy. It's very floppy. It's not very rigid. It's not as rigid. Okay? So what happens is that when they begin to exhale out, before they have completed their exhalation, their airway will close up. What we call that is COPD patients have early airway collapse. Early airway collapse. Okay, because of their airway, floppy airway. Okay. Winning PEEP. Win in decrements of 2 to 5, 3 to 5 to maintain good oxygenation. If you have normal oxygen saturation, then you turn your PEEP down. Okay, but now remember now, before you can start turning your PEEP down, your FiO2 must be less than 60. Okay? Complications of PEEP. Hypertension is positive pressure. It will decrease venous return to the right side of the heart, decreases cardiac output, decreases blood pressure, decreases perfusion. Barotrauma, yeah, too much of it will rupture a lung unit. The air will begin to leak out. The air goes into the pleural space. You got pneumothorax, it goes around the heart. You got pneumopericardium, it goes into the stomach, pneumoperitoneum. Pneumoperitoneum, yeah. It goes under the skin, you have subcutaneous emphysema, okay? Decrease in lung compliance, yes. Although a PEEP improves compliance, it can also cause a decrease in lung compliance, meaning that you have overstretched the lungs. Too much pressure there will overstretch the lungs, causing compliance to fall. Okay? So PEEP is good, PEEP is bad. Too much of everything is bad. It can cause increase in dead space. PEEP can cause increase in dead space because here's the alveolus here. You started with the pulmonary capillaries like this. And then all of a sudden, you added a PEEP of 20. That's more area for these capillaries here to perfuse. Now, just because you added PEEP doesn't mean that God is going to make more pulmonary capillaries for you. It doesn't work that way. So dead space is ventilation without perfusion. So we have the air still coming in. But we cannot perfuse this big area. Another way to look at it is you can compress the pulmonary artery by using high PEEP. If you compress the pulmonary artery, you have reduction in blood flow to the lungs. Okay? Increase ICP, yes. That's true. PEEP will cause you not to return a lot of blood from the upper portion of the body. The blood is backing up in your brain. And then you have increased ICP. Any questions? Treatment for other PEEP. Yeah, we can do something about other PEEP, but that's why we check it anyway to see if the patient has it. One way you can fix it on the ventilator, if you're on a volume control mode, pay attention to this now. If you're on a volume control mode and you have other PEEP, the best way to do it is you increase your flow rate. Because increasing the flow rate decreases the I time and gives you more time to exhale out. Increase the flow, decrease your I time, and lengthen your E time on a volume controlled mode. Because on a volume control mode, we set flow, so you can control flow. Decrease minute volume, yes. If you know that your minute volume is very high, normal minute volume is what? I want to say 5 to 6 liters per minute. It's normal minute volume. Now, here's somebody that's got a minute volume of 12. That's a lot of volume that they may not be able to exhale out. You can decrease that. So you have to be careful with minute volume and tidal volume, because decreasing those could result in your CO2 rising. Okay? So you have to be very careful. You have to make sure that if you decrease it, the level that you decrease it to, it will be enough for the patient. Okay? Decrease respiratory rate, yes. If I'm going, my expiratory time is lower. If I'm breathing very fast, your expiratory time is small. Okay, so if you decrease respiratory rate, you lengthen the expiratory time. On pressure controlled mode, we don't set flow. We don't set flow on pressure controlled mode. So if my patient was on a pressure controlled mode and they were air trapping, I would decrease my respiratory rate, because I can't control my flow there. You can decrease mean airway pressure. You all remember the mean airway pressure? Everything is in it. The PRP is in it, the PEEP is in it, the I time, all of that are in there. So make any adjustment to decrease your mean airway pressure, that will work. Okay. And then the last one is institute PEEP. Remember we talked about the actively contracting expiratory muscles, where the airway will close up, they have any airway collapse. So if you know that somebody is air trapping, you give them that amount of air trapping that they're doing. For instance, let's say my patient has auto PEEP of 3. I'm currently set on PEEP of 5, that's what I said, but my patient is trapping 3, same it upward. What I can do is to increase the set peak to 8. So I'm giving them back what they're trapping. That helps to rigidify their airway. So you give people the same amount of air trapping that they're doing, especially COPD patients. All right, so now that we've gone over